In this video, we'll discuss about H. pylori gastritis. H. pylori associated gastritis will discuss the normal anatomy and histology of stomach. As we know, the stomach is divided into a four part: cardia, fundus, body and pylorus. So stomach divided into four part: cardia, fundus, body and pylorus. If we open the stomach, what we see? The gastric rock and depression. We can find out gastric rock and depression in the stomach mucosa. That one name is called as gastric pit. So these are the deeper part of these pits. That one name is called as gastric gland. Deeper part of this pits name is called as gastric gland. So when we can cut, we can find out gastric rock and depression of the stomach. That name is called as gastric pits. So this deeper part name is called as gastric gland. Next, histology of gastric gland. In the fundus or the body, which is mainly ascending gland. The main important cells which we see in this type of gland: chief cell which secrete digestive enzyme like pepsinogen. Then parietal cell which secrete gastric acid, which secrete gastric acid. Then D cell. The D cell secrete somatostatin and enterochromaffin cell. This one secrete atrial natriuretic peptide. So this one will secrete atrial natriuretic peptide. So this one is the fundus or body. Mainly it having gland name is called as ascending gland. It having chief cell, parietal cell, D cell and enterochromaffin cell. This fundus or body having ascending gland. Chief cell secreted pepsinogen, parietal cell secreted gastric acid, D cell secrete somatostatin and enterochromaffin secrete atrial natriuretic peptide. Then we look into histology of that pylorus. These are the pyloric gland wherein we find the D cell. D cell secrete somatostatin and G cell secrete gastrin. Then we also have enterochromaffin cell. Remember, the G cell are presented in that pyloric gland, whereas parietal cell is presented in ascending gland. This is the difference. Here G cell is presented, the ascending gland is presented. Normally what really happen is this G cells are the one which secrete gastrin. This gastrin stimulate these parietal cells to produce acid secretion. So here what is the thing? The G cell secrete gastrin and the gastrin stimulate that parietal cell to produce the acid secretion. But then again we have D cell next to G cell. D cell next to the G cell which is secrete somatostatin. The D cell secrete somatostatin which is the negative regulator. This one, the somatostatin, is the negative regulator of that gastric secretion. So what will happen? Now they sort of inhibits this G cell. So it inhibits G cell to reduce the secretion of gastrin. Thereby it prevents the secretion of acid by this parental cell. So D cell having somatostatin, which is the negative regulator of gastric secretion. Now they sort of inhibit of the G cells to reduce secretion of gastrin. Thereby it prevents the secretion of acid by this parental cell. Let's look into that normal defense mechanism. Why do we need to understand this defense mechanism? So we know the stomach mucosa contain acid and pH that has the potential to cause damage to the epithelial cell, but the normal gastric mucosa has productive factors. And what are those productive factors? So stomach mucosa containing acidic and pH environment, they causes damage to that epithelial cell, but normal gastric mucosa has productive factors. What are the productive factors? First and foremost things is that mucus secreted by that foveolar cell. First one is mucus secreted by foveolar cell. It form a layer above the epithelial cell. It form the layer to that epithelial cell. They form a layer above the epithelial cell, above the gastric epithelial cell, which prevent the acid from being diffused into the epithelial cell. Second one is bicarbonate ion, again secreted by the surface epithelial cell, which sort of neutralize the acid. A third important mechanism is gastric epithelial cell themselves forming a physical barrier, and that limits back diffusion of acid. Then fourth one, epithelial regeneration. The gastric epithelial cell, they are replaced by every 3 to 7 days. Fifth one is rich mucosal vasculature. What does that do? That delivers oxygen and remove acid which may have diffused into the lamina propria. Last one is elaboration of prostaglandin E2 and prostaglandin I2. Now what does this do? This is the one which is responsible for all the above action. What are the action? Mucus secretion, bicarbonate iron by surface epithelial cell, gastric epithelial cell, all the things. All these are brought about by this prostaglandin E2 and I2. If any of these defense mechanisms are damaged due to various injurious agent and result in the development of gastritis. So what are the defense mechanism? We have mucus secreted by foveolar cell, then bicarbonate, then gastric epithelial cell forming physical barrier, then epithelial regeneration, then rich mucosal vasculature and elaboration of prostaglandin E2 and I2. If any of these defense mechanisms are damaged due to various injurious agent, result in development of gastritis. Then some terms. Gastropathy. Gastropathy is inflammation of gastric mucosa, which where the inflammatory cells are very minimal or even absent, whereas gastric are the one which have inflammatory cells in the form of neutrophil. That's why we need to understand difference between gastritis and gastropathy. Now let's see what H. pylori does. How does this organism injure the gastric mucosa? What is this? Helicobacter pylori. Okay, H. pylori full form Helicobacter pylori. These are slender, curved rod with polar flagellum. One end of these bacilli containing multiple flagella, and these are the one responsible for rapid motility. By using flagella only it can move. By that action of these flagella, they are gram-negative bacilli, and remember they are the only human bacteria to persistently inhabit that gastric mucosa. So this one and only bacterium only presented in gastric mucosa, and they solve non-drug cause of gastritis. They solve non-drug cause of gastritis and gastric and duodenal ulcer, and they cannot colonize duodenum or esophagus unless they have undergone gastric metaplasia. Normally, most of the H. pylori free living in that mucosa. We know that organism from that luminal aspect enter into the mucus layer by motility due with the help of that flagellate. They bind to the blood group antigen, particularly that Lewis B blood group antigen, which are expressed on that gastric epithelial cell. So Helicobacter pylori, slender curved rod with polar flagellum, one end having puncture flagellum, used for motility. So this one bacterium only presented in our gastric mucosa. This one is the non-drug cause of gastritis and gastric and duodenal ulcer. Cannot colonize in duodenum and esophagus. Then most of the H. pylori are free living in mucosa. A small portion is attached to that epithelial cell at here it will attach to that epithelial cell at mucosa. H. pylori adhere to the cells by outer membrane protein. Then they bind with blood group antigen, namely Lewis B expressed the gastric epithelial cells. Then what are the unique bacteriological features? These organisms have unique bacteriological features like flagella responsible for motility. Thereby this organism moves or seem to less acidic locally beneath the gastric mucus. Second one is urease generate ammonia which increasing pH and allow organism to persist in low pH. Second, this bacteriological feature, first one is flagellum, second one is urease generate ammonia which increasing pH and allow organism to persist in low pH environment also. Third one is vacuolating cytotoxin A, VAC-A, which is a cytotoxin. This one is the cytotoxin. So, unique bacteriological feature, flagella, urease, and vacuolating cytotoxin A, VAC-A. This one is the cytotoxin. Fourth, unique bacteriological feature, cytotoxin associated gene A, CAC-A. First one is VAC-A. This one is cytotoxin associated gene A. This is the pro-inflammatory and pro-proliferative agent. This one is the pro-inflammatory and pro-proliferative. Once attached, once adherence of bacterium to that surface of that epithelial cell, it form a transmembrane channel. This one will form transmembrane channel, and through the channel, this VAC, that means vacuolating cytotoxin A and cytotoxin associated gene A are released into that gastric epithelial cell. So it will releasing VAC and CAC gene. VAC A. What is VAC A? It is a toxin, that is cytotoxin, that form channel in the lysosomal and endosomal membrane. This one generating multiple large cytoplasmic vacuoles. VAC-A is a cytotoxin that form channel in that lysosomal and endosomal membrane. This one generating multiple large cytoplasmic vacuoles. Then VAC-A also result in alteration of D cell function. VAC-A result in alteration of D cell function. And this GAC-A, which causes reorganization of actin filament and stimulation of cytokines, leads to recruitment of inflammatory cells towards the site of injury or towards the site of organism. CAC-A causes reorganization of actin filament and stimulation of cytokines, lead to recruitment of inflammatory cells towards the site of injury or towards the site of organisms. So this VAC and CAC, this one, this combined effect of all these enzyme, formation of vacuoles, reorganization of filament, alteration in the D cell function, and then recruitment of inflammatory cells is basically our acute or chronic inflammation, that is gastritis and gastric epithelial death. The cytoplasmic evolution induces apoptosis in that gastric epithelial cell and causes gastric epithelial death. It causes gastric epithelial death, which leads to formation of gastric ulcer. So this is how gastric ulcer formed. So this one immunosuppressive effect, then form channel in lysosomal and endosomal membrane. This one generate multiple layer cytoplasmic vacuoles. Then this one is altered D cell formation, VAC 3 function. Then CAC, reorganization of actin filament, then stimulation of cytokine inflammation, then gastric ulcer. So all the things from acute and chronic inflammation, gastritis or gastric epithelial cell death. So finally it forms gastric ulcer formation. GAC-A is also the interaction of this category also leads to growth promoting oncogenic signals, and that's how there is development of gastric cancer. VAC-A is the one which has inflammatory immunosuppressive effect, which result in immunosuppressive effect. That is the reason why there is not much natural immunity to this H. pylori infection. Next one is pathogenesis. Pathogenesis depends on virulence factor CAC-A, VAC-A and PAP-A. PAP-A is responsible for addition. CAC-A is the pro-inflammatory, pro-proliferative, and VAC-A is cytotoxin. PAP-A used for addition. Second pathogenesis factor, host genetic susceptibility. It is very important because if the individual has polymorphism in human cytokine gene, particularly interleukin 1, which are basically free inflammatory. So polymorphism in this set of gene make the individual more susceptible to the development of inflammation. Then next third one is the cofactor is the environmental factor, smoking. So pathogenesis depends on virulence factor, host genetic susceptibility. Why some develop gastric ulcer and few develop duodenal ulcer? In G cell release gastrin, and this gastrin stimulate the production of acid by parental cell. So what is the process? G cell release gastrin, and this gastrin stimulate the production of acid by parental cell. And D cell, the somatostatin is the negative regulator of the G cell. That is the normal mechanism. Now what happened? This H. pylori result in decrease number of D cell. So here what will happen? Decrease number of D cell result in decreasing somatostatin production. And that what happened if there is decreased production in somatostatin production, the normal inhibitor effect of the D cell is lost. So what does that result in? Continuous stimulation of G cell. So what is the result? Continuous stimulation of G cell, continuous secretion of gastrin by this G cell. So there will be increased release of gastrin. And the second mechanism, what will happen? Being inflammation directly. So second one, it will cause us inflammation directly. They stimulate G cell to produce more and more gas. Now we have to condition is called hypergastrinemia condition. What happen after that? Two things can happen. One depends upon the type of gastritis involved. One, if the gas state is involved is predominantly corpus or pan-gastritis. So hypergastrinemia condition. So in this one, two condition will happen. One depends upon that gastritis involved one. So here what type of gastritis? Corpus predominant or pan-gastritis. If that gastritis is involved in until predominant gastritis. So two entities. One of pan gastritis, entire gastric mucosa is infected or affected. Second one is antral predominant gastritis. So in corpus predominant gastritis, there is decreased acid production. That's because even that parental cell are damaged. There are no parental cell, result in acid production, leads to gastric atrophy. And this gastric atrophy over of time resulting in gastric ulceration and gastric carcinoma. Now if it is antral predominant gastritis, that really happen in that there is increased acid production because of hypergastrinemia. This gastrin goes and stimulate the normal parental cell to synthesis more and more gastric acid. So because of more and more gastric acid which is transported to the duodenum, thereby resulting in damage to the duodenal mucosa, resulting in duodenal ulcer. So this is the mechanism of formation of gastric and duodenal ulcer. Now we saw that H. pylori induced gastric atrophy, which H. pylori induced gastric atrophy, which progresses to adenocarcinoma even if H. pylori is treated. How gastric atrophy is implicated in adenocarcinoma? Let's understand this gastric atrophy result in increased ROS, reactive oxygen species. That's because of more and more inflammatory cell. Second one is overgrowth of other bacterium. Third one is loss of zonic Hancock expressions. So because of three things, understand that gastric atrophy result in increased ROS, overgrowth of other bacterium, then loss of zonic Hancock expression. What is Hancock expression? Whatever there is the zonic Hancock expression is the main cause of the cell polarity. Whenever there is loss of zonic Hancock expression, that expose the cell to mutagenic agent. So the combined effect of all these three increase risk of development of gastric adenocarcinoma. Coming to clinical features of H. pylori: nausea, upper abdominal pain, gastritis, peptic ulcer disease leading to nausea, anorexia, vomiting, epigastric pain, belching. Some individual can be asymptomatic for decades. Then perforation can lead to extensive bleeding and peritonitis. Then diagnosis method: most sensitive one is endoscopy. Then we'll do biopsy and culture of gastric mucosa. Then non-invasive method, serology. In the serological method, identified antibody in that serum. Then urea breath test. Urea breath test. Urease produced by H. pylori, we know. This urease result in labeled carbon dioxide which appear in that breath. So injection of radio labeled carbon 13 or 14. Urease in stomach means this one converted into carbon dioxide and water. Then stool antigen detection by sensitive indicate. This one is the sensitive indicator of colonization, stool antigen detection test. Then special staining can be done. Biopsy section, normal staining, H and E staining. Here special staining, Jimsa staining, tip cook staining, Warnithin story staining. Then in the case of difficult cases, immunohistochemistry, and especially after therapy where H. pylori is not identified easily, then we can use that molecular technique, polymerase chain reaction. Then treatment, 90% of cure rate with quadruple drugs therapy. 90% of cure rate in quadruple drugs therapy given for 14 days. Then combination of bismuth subsalicylate, then proton pump inhibitor, tetracycline, metronidazole. These are the drugs control H. pylori. Thanks for watching.